This is just probably one of the better diagrams that's out there that kind of represents, this will be helpful for your spinal cord lecture too, but the spinal cord, most of the pathways that are in that spinal cord, both motor and sensory. It also does a nice job of, for example, it breaks things into like the posterior funiculus, but then it breaks it further into fasciculus, gracilis, and cuneatus. Um, it doesn't have all the pathways for motor and sensory on here. It has most of them. This is a thoracic level spinal section. The reason you know it's thoracic level is because it has that little lateral horn right here, which is associated with where the cell bodies are for sympathetic, preganglionic sympathetic neurons that are located there. So that's how you know it's a thoracic level. So there's actually a couple motor tracts we'll talk about today that end in the cervical spine. They don't make it down to the thoracic spine. So when you're looking at this on this side of the spinal cord, they show most of the motor and sensory pathways all there. There's a couple motor pathways you won't see because they're gone once you get past the cervical spine. So that's all I wanted to mention there. But this is nice that it just shows, it shows you the dorsal root, shows you the ventral root, dorsal root ganglion, shows you where they first joined together, where they are called the spinal nerve, right where they join together, okay? And at that point in the spinal nerve, you have sensory neurons, you have motor neurons, and you have autonomic neurons, okay? And then from there on, all the nerves, as they go out to the various parts of your body, all contain some motor, some sensory, some autonomic fibers, okay? You'll also notice, I think I drew this out in the autonomic lecture, where there was like a cross-section through a spinal column that was in like an actual drawing of a human body kind of thing. But as soon as you have that spinal nerve comes out, it divides very quickly into what's called a dorsal ramus, and then this is the ventral ramus. The dorsal ramus there's actually motor, sensory, and autonomic that goes to the back part of your body. Right down the center back part of your body, the dorsal ramus goes back there to supply muscles of your spine, of your glutes, of your posterior cervical muscles, and the surface of your skin. Sensory, motor, autonomic. The dorsal ramus just goes back there. The ventral ramus that goes out, which is still oftentimes considered the spinal nerve here, even though it's really the ventral ramus at this point. The spinal nerve is really only that little tiny segment right when those join together before you divide into the dorsal ramus and ventral ramus. But really, most people would still call this as essentially like a spinal nerve because it has all the information from that one spinal segment, okay, coming out of it. And then you can just see where it goes to as far as the motor, sensory, and autonomic functions that are influenced by that ventral ramus. But then you also see, this is also, we're at a thoracic level because we actually have a sympathetic trunk ganglion, okay? Because we only have that in that T1 to L2 region, okay? So we're in that. We know this must be a pretty high thoracic spine because we actually have a fasciculus, gracilis, and cuneatus here, so we got to be above T6. So probably in the T2, T3 region with this. Don't have to know that now. When we get to spinal cord, those are little clues that helps you understand where you are in the spinal cord. If you just see a cross section, they give you some clues about where you might be. Okay? All right, so that's just a reference to go back to for your own purposes. So we are on to motor system. Believe it or not, I used to go watch tractor pulls out in San Diego. They used to actually have them at the stadium there, these tractor pulls. It was impressive once. I mean, it's fun to see once, just to see like 10 engines, nitro, with nitro fired up all at one time and watch one blow or something like that. You're just hoping one of the engines blows while they're doing that. But I'm assuming they still do this stuff. I'm assuming, does anybody go to like tractor pulls or anything? Come on, there's got to be one of you rednecks out here. Or do it on your own, have your truck, your 4x4, go pull some stuff. So here's our schematic of the motor system. So similar to what we did with the somatosensory system, we're going to do that with the motor system here. Here are, we start with our major components of the motor system. We have our cerebral cortex. So the cerebral cortex up here, that's key for, and there's different regions, and we'll get to that today, are key for voluntary, when you actually decide to move, okay? Doesn't help you much with involuntary or reflex kind of, types of movements, but it's very important for voluntary movement. We have what your book refers to then as the control circuits. The basal ganglia and the cerebellum are very important for influencing motor output overall. The cerebellum is very important for the coordination and error correction ongoing with motor output, okay? Which we'll get to, that'll be our Tuesday lecture, is cerebellum and basal ganglia. Basal ganglia plays a role in modulating the excitability and amplitude of movement that actually occurs. So when you send a signal to tell your muscles what to do, it actually has to go to the basal ganglia first. Basal ganglia processes it, and then the basal ganglia then allows the signal to be released and eventually go to the muscle, and it helps to modulate how the amplitude, the force, how quickly that occurs. It has to get processed through the basal ganglia, okay? Basal ganglia is kind of maybe like, if you give a car analogy or something, like your fuel injector or your carburetor in your car that determines actually how much gas gets squirted into the cylinders when you push on the gas. You're pushing on the gas as you deciding to move. The basal ganglia then determines how much gas gets squirted into the descending, or how much activity gets squirted into the descending pathways to make your muscles move. And that's why people with Parkinson's who have problems with their basal ganglia, they can't get moving enough, because when they press on the gas, not enough gas gets squirted into the, into the pathway to fire the muscles, okay? So that's the basal ganglia. Then we have the descending motor pathways. So once you've made the decision to move, once it's been processed in the basal ganglia and a copy of that message has been sent to the cerebellum, it has to go down these pathways that are going down through the brainstem and spinal cord, okay? So they're efferent, descending motor pathways. We can grossly divide this into two major categories: a medial activation system and a lateral activation system, okay? Kind of like we had the anterolateral system, and we had the dorsal column medial lemniscal system. So then we have a variety of tracks. And we're going to talk about 5 tracks associated with the medial activation system, and we're going to talk about 3 that are associated with the lateral activation. So only 8, that's a piece of cake, right? Instead of what, do we have like 11 or something with the somatosensory? Some of these you can group, a little bit in your mind, so we'll talk about that. Once it goes down that descending tracks in the brainstem and spinal cord, eventually it's going to communicate with a motor neuron in the anterior horn and send a signal out. And it's going to activate both alpha motor neurons, which go directly to the striated muscle fibers themselves, or it's going to activate, and typically this happens simultaneous, a gamma motor neuron that's also going to go to the muscle spindles embedded in those muscles so that they contract almost simultaneously, okay? So that is how that works. So how do we move? It's a very complicated process to make it look coordinated, but it involves the peripheral, spinal cord, brainstem, cerebellar, or cerebral regions. It's shaped by a specific context and directed by the intentions of the performer, if it's a voluntary task. Always, always, whenever we talk about motor learning, motor control, when we get to clinical neuro, whenever you're moving within an environment. So the environment shapes what you do. If I'm standing on sand versus a firm surface, how my muscles have to respond to destabilization and keeping my balance is totally different. Or if I'm working in an environment where it's dark, or where I'm lifting something very heavy versus something very light, that's always going to shape the context. So you can't separate that out. Movement is always influenced by the environment and also by the performer themselves. Their own intentions, their motivation, all those things influence how we move, okay? Why do we move? That's how we interact with the world. That's how we make things happen. That's how we influence the world, okay? Locomotion, be able to move from one place to another, is an essential trait of being a human being. And it's the one thing that most of your patients, when they can't do that, that's why you're their hero. Because they say, I go, what's your goal? I want to walk, I want to move from here to there. I don't want to have to have somebody help me do that. You hope you can get them doing that with their legs as a form of locomotion, but wheelchair is a form of locomotion, and sometimes you have to make them appreciate that's a perfectly acceptable way to get from one location to another. Okay, it's how we explore our environment. It gets rid of our constraints. They theorize, so our frontal lobes include our primary motor strip, and then everything in front of that's kind of this prefrontal cortex, and that in evolutionary terms, we've developed the ability to move and interact with our environment, and then because of that, we could learn from trial and error by changing our environment and seeing what happens, and then that fostered the further evolution of our neo-prefrontal cortex that allows us to think, and executive functioning and all those kind of things came afterwards. And you can't separate the motor system from the cognitive system, and so it's very important. So more than half of our nervous system is actually directed towards motor performance, and the most common manifestation of a neurologic disease is a motor loss, some type of motor dysfunction or motor loss. Often always accompanied with some other, motor systems, sensory systems, they're all close to each other. They're all in these like spinal cord, brainstem regions. That you can have, it's when you get to the cerebral cortex where things get more separated and farther apart and are spread over larger regions. But if you have damage somewhere in the brainstem or spinal cord, you're almost always going to affect motor and sensory. Not always, but it's very common. Very common to have both, and maybe even some autonomic function could be impacted. When you get up in the cortex, though, up in your brain, then you can have motor, sensory, autonomic, but also cognitive, perceptual, those kind of things. This is where you start to see a combination of those things when you have lesions up in the cortex. So here's that kind of sequence again that I've already explained. You make a decision to move. This is voluntary movement, okay? You decide to move. That starts in the motor planning areas, which is the premotor and supplementary motor areas. Those are just in front of the primary motor strip, okay? So you think, I'm going to do this activity. If it's something you've done before, or it's kind of a stored program, a lot of things we do are stereotypical in nature, we've done them before, you tap into that kind of stored program, you send a signal to the control circuits. Some of that goes to the basal ganglia. A copy of what you're going to do goes to the cerebellum, but it has to get processed in the basal ganglia, go back up to the primary motor strip, and then you release the signal from the primary motor strip down to the descending motor pathways to send a signal to either directly onto the lower motor neurons or to some of the spinal interneurons nearby those lower motor neurons to influence the lower motor neurons in general, to then elicit and send a signal to the individual skeletal muscles that do the action or perform the action. Okay? Yeah. They can, in a sense. They do change. You have these interneurons that are around those anterior horn cells, and when you send that signal down to both the anterior horn cell directly or to the interneurons, it shapes the total, what's going to eventually go out of that anterior horn cell, because some of those signals might follow some inhibitory interneurons, some are excitatory, and that's how you fine-tune the signals that are going to go out. And so you may be wanting, actually in some particular functions, for example, when you're doing very discrete movements, like trying to do fine movements, you actually may want to send a signal down to very specific muscle fibers to move your finger in a specific way, but you may want to actually inhibit muscle fibers right next to it. And so you might send some inhibitory, or your signals might follow some inhibitory interneurons that are nearby that muscle fiber to quiet the muscle fibers that you don't want to interfere with the primary motion you're trying to achieve. Does that make sense? So it's just another layer or level of adjusting output. So we're going to go in your book's order. I'm not as, they start lower motor neuron and kind of work their way up. I'd rather go top down, but that's okay. Well, I just keep it in the context of your book so we match up with the way you're reading and thinking. So We're going to start the lower motor neuron, okay, that final common pathway there. So there are two types of lower motor neurons. The one that you think about that actually makes the muscle move is the alpha motor neuron, is what it's called. The cell body is in that ventral or anterior horn of the spinal cord. It exits, the axon of it exits out the ventral root. It innervates what's called extrafusal skeletal muscle fibers, okay? The neurotransmitter it releases at the motor end plate, at the neuromuscular junction, is acetylcholine, and it falls on some nicotinic receptors. It's a fast ESP, fast, works, okay? And it's on large myelinated A alpha fibers. So in this case, the nice part about the motor system is there's only two types of axons. There's the A alphas and the A gammas, okay? So the ones that go to the striated muscle is the A alpha axon type, large myelinated, okay? So this is just showing you this is a group of anterior horn cells. We'll just look at the one here that's actually sending its axon out to an individual muscle fiber. And this is the A alpha type of axon, exits out. This is the ventral root. There's little rootlets before it actually forms together to form the ventral root. There's these little rootlets. You see here, there's dorsal rootlets back here. When we talk about the spinal cord, this is the spinal cord segment, okay? And so here's the dorsal root ganglia, but then it divides in these little rootlets right before it goes in, okay? They're still all considered part of the dorsal root. This is all part of the ventral root. Then we have gamma motor neurons, okay? So those are the ones that are sending a signal to the intrafusal muscle fibers, those little muscle fibers on each end of the muscle spindle that are embedded within the striated skeletal muscle, okay? They also are located, here's an alpha and a gamma. They're all located in the anterior horn cell, all mixed together. And they tend to fire simultaneously. When you send a signal down to an alpha motor neuron, you're also sending signals to gamma motor neurons at that same spinal cord level. And you contract your muscle spindle also contracts. But it contracts like a few milliseconds later, because it's actually the signals, the axon type here of a gamma motor neuron is a medium myelinated A gamma. So that's a gamma symbol, A gamma axon. And it's a little slower. So when you fire, you'll fire the muscle first, and then just a few milliseconds later, the muscle spindle starts to contract to adapt to the new length of the muscle. And we'll talk about this alpha gamma coactivation in a little bit here and why that's important. We want to define some terms here. So one of the terms you want to know is what a motor unit is. A motor unit is a single alpha motor neuron, and all of the muscle fibers are innervates. So here is an alpha motor neuron that would be located in that anterior horn of the spinal cord, and it has an axon that comes out, and that axon divides, and it may innervate just a few motor fibers or muscle fibers, or it may innervate a lot. Depends on typically the region of the body that you're talking about. So for example, in the quads, you have like these large motor units. So like one cell body that's massive will send a signal to like hundreds of muscle fibers in a quad, because a quad just fires like, it's kind of like all or nothing. You're not having to fine tune quad muscle to make sure it's just extending the knee, or it's pressing, or it's just contracting to extend the knee or extension, okay? Where if you're trying to work fine-tune forearm muscles, intrinsic hand muscles, you have much smaller motor units. So you'll have lots of little anterior horn cells that are going to a smaller number of fibers, so you can selectively turn on just small regions of the muscle to get that more fine movement that you're looking for, because you want to move your finger just this way. So that's going to take just firing these few muscle fibers, but not those. And that's why you tend to have, in the lumbar spine, you tend to have larger motor units with fewer motor neuron pools, which we'll get to in a second what a motor neuron pool is. But in the upper body, you tend to have these smaller motor units, but lots of them, okay? So motor neuron pool, which is right here, that is all the alpha motor neurons that are going to individual, they're all going to all the different muscle fibers that supply an entire muscle. So it's all the alpha motor neurons supplying all the muscle fibers of an entire muscle. That's what we call a motor neuron pool. So in the upper extremity, like this, you'll tend to see, lots of alpha motor neurons that may be actually, the size of them may actually be a little smaller because they're only interacting with a smaller number of muscle fibers, but you have to have a lot of them to supply this muscle. Now the bicep's a pretty gross movement muscle, so it's more your intrinsics of your hand, your forearm that have this. But then in your quads, you may see just a smaller number of motor neurons in here, maybe 3 or 4. Actually, it's a lot more than that, but compared to this relative size, and they're going to larger number of muscle fibers, and the cell bodies might even be bigger because they have to work and generate signals to a big, large number of muscle fibers, but there's less of them. Another thing just to mention here as far as is this concept of fast and slow twitch motor units, okay? So we have different types of muscle fibers, fast and slow twitch muscle fibers, but what's interesting is whether your muscle is a fast twitch fiber or a slow twitch fiber is entirely dependent on the nerve and the type of innervation it's getting, okay? They've actually done studies where you can actually take a nerve from a slow twitch muscle fiber and swap it to a fast twitch and vice versa, and it'll turn that muscle into the new properties of the nerve that's going to it, okay? So there's some subtle differences in the types of nerves going to these and where it's coming from. So slow twitch are typically your type 1. Those are your posture and slowly contracting muscles. Those are the ones that are turned on all the time, provide that background posture. Core, proximal muscles tend to be more slow twitch to some extent, except for like some of the glutes and those kind of things can be more fast twitch, but more of your spine, skeletal, spine muscles and core, deep core muscles of the abdominal region and so forth tend to be more slow twitch in nature. Okay. Then fast twitch, which can be subdivided into a type 2A and a type 2B. Type 2As are a little more fatigue resistant. Type 2Bs are the ones you use when you're doing a maximum like jump or a maximum sprint that's very short, like 40-yard dash or something like that, where the type 2A is something where you're doing something more explosive, but it's more sustained. Maybe you're doing a 400 or 800, something like that. You're tapping more into type 2As versus if you're, doing just a shot put or something like that. That's somebody who's going to be using more type 2Bs. But you're using all of them all the time. There's just some overlap, or just what proportion of those types of fibers you're using for any given task just changes, but you're always using all different types of slow and fast twitch fibers for almost any given task. Okay. What's interesting is you think slow twitch, it's going to fire slower, which the muscle can fire a little slower, but however, the signal for your slow twitch fibers actually gets to them a little quicker than your fast twitch fibers. Because if you're going to do some explosive movement like a counter movement jump or something like that, or a long jump, you need to have your core ready to tolerate the forces you're going to place on it. So because the cell body in the anterior horn cell is a little smaller, it actually depolarizes a little faster and easier. So when you send those signals down to the fast twitch fibers, the slow twitch fibers are getting a signal too, and they actually arrive just a fraction of the time before the fast twitch fibers fire. So you set your core, and your slow twitch muscles so that you can do the powerful contractions. So it's not about how fast the timing of the contraction. Even though they contract a little slower, the signal gets there in enough time ahead of the other signal to the fast twitch, they still have time to contract before the fast twitch muscle fibers do. Remember, the thing about the motor system, it's heavily influenced by sensory input. all of our motor activities, as we're moving and interacting with our environment, we're receiving sensory feedback by whatever we're touching, how heavy it is, the type of surface we're on. We're getting all that, and that is coming into the spinal cord, and it's going up to the brainstem and the cerebral cortex. And at each of those levels, it can actually influence the next signal coming down to our motor system to alter it, to adapt it so it's optimal for the environment and what's going on in the world. So some of those are GTOs, muscle spindles, are two of the more important ones, okay, that really give us a lot of quick feedback about what our muscles are doing and the tension in our muscles. And then, of course, we have our joint receptors, you know, and those kind of things that also help with that. And that information can be processed on multiple levels. So this is just showing you, here's an anterior horn cell. There's actually input. So there's input coming down from descending pathways that go directly to the muscle spindle. We also have information coming from interneurons nearby, both inhibitory interneurons and excitatory interneurons. And then also we get direct input from muscle spindles and GTOs right at the level of the spinal cord. Some of that information also goes up to the brainstem and the cerebrum and then influences the next signal coming down. So you get immediate influence at the spinal cord level, but then you also get influence from higher centers once that sensory information has been processed and the next signal is sent down. So there's a lot of processing and influence from the sensory system over the motor system. So I mentioned this concept of, with a muscle spindle, of alpha gamma coactivation, okay? So during movements, you get both the alpha motor neuron and the gamma motor neuron firing at the same time. And the reason this does this is to adjust the sensitivity or gain of the muscle spindle inside that muscle. So let's just take a muscle. Here's a muscle at rest, at its resting length, okay, that first picture on your left. Your muscle spindle actually fires constantly, and it's giving a constant, it's got kind of a base firing rate. It's going beep, 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 and that's telling your brain or your spinal cord or your brainstem that my muscle is this long right now, and it's at its resting length, okay? Now you contract the muscle, or the muscle shortens. Somebody shortens it for you, or you contract it, right? You contract the muscle, and the muscle starts to shorten. Actually, this would not happen if somebody did it for you. This is where you contract it yourself, because this is about alpha gamma coactivation. You're turning the muscle on, and you're sending a signal to the muscle, but also sends a signal to the motor unit. So what happens initially, though, when your muscle shortens, so this is the afferent signal. This is the afferent part. This is the gamma motor neuron to the little muscles at the end of the muscle spindle. But you'll notice that now the signal, you no longer see that pulse. So the pulse rate went down, or the signal went down, and that tells your brain and your brainstem and spinal cord that that muscle got shorter, because you're not getting as much pulses or action potentials from the resting position of that muscle spindle. Now the problem there is, now that I've got this new length in that muscle and it's shortened, it's no longer sending signals. Once I'm now at that new position, if I were to shorten it further, there's no more room to have that adjust that sensitivity. So the signals have already been shut off. If I go shorter, it's not going to tell me it went any shorter, because it's not going to give me that ability to determine that, because those signals have already stopped. So what I need to do is a fraction of a moment after I shorten that muscle, and it's told me it's shortened, the gamma motor neuron kicks in and shortens the muscle spindle. So now that it's at a new resting length within that shortened muscle, then you start getting your base pulse rate of activity out of that muscle spindle. So now it's ready again. If I shorten it even further, I have the ability to notice that that pulse rate goes down. If I lengthen it, it'll go up, and that'll say it means your muscle's getting longer. Okay, but it resets the sensitivity of that muscle at the new length. I just don't want to have a floppy muscle spindle there that isn't ready for even getting shorter, and so forth. So that's what the alpha gamma coactivation does. It just maintains the sensitivity there. So some theory on, there's a couple different types of therapy that people do. One's called the Jones technique, and there's a couple variations on this where they claim that they're basically resetting the muscle spindle. So somebody who has like an overactive, spastic, facilitated muscle, like, oh, I got a spasm in my neck or something like that. what they will attempt to do is basically, and so what that they theorize that your muscle spindle is sending lots of signals to say this muscle's got lots of tension in it, it's in spasm, and it's sending signals back to your sensory system and back that's saying it's keeping it in spasm. And so what they do is they'll tell you to totally relax, and they'll take that muscle and they'll try to shorten it as much as they can without you contracting it. So they're trying to turn off the muscle spindle without you activating the gamma motor system. Then what they do is they hold you in that position for whatever, 30 seconds or a minute, keeping the muscle spindle shut off, if that's how it works. Nobody's ever really determined. You can't stick a EMG directly into a muscle spindle, so it's really hard to see if this is happening at the muscle spindle level. Then they'll maybe have you do some deep breathing, and then think good thoughts, and then they position you slowly back into the same position with trying not to elicit your muscle spasm, and then they hope that the muscle spindle now is sending a signal that is more correct and baseline, and that kind of resets the system or something like that. Now that may be part of it, but there's lots of, a lot of it has to do with the joint receptors are stimulating when they do that, so it's not just the muscle spindle, but that's one aspect that they think they're doing kind of to help short circuit a spasm. And that may be some of the stuff that goes on where they think with dry needling, they don't know. Are you doing something to the muscle spindle in addition to lots of other things typically? Now we're going to just talk about the spinal region a little bit and talk about the types of motor control and activity that happen just at the spinal cord level without a lot of influence from the brain or higher centers. There's actually a lot of activity, a lot of motor output that occurs just at the spinal cord level without a lot of influence from even walking. Once once your brain tells you to start walking, your brainstem and your spinal cord keep you walking without a whole lot of effort. You don't have to think about it while you're walking. It's only when you turn or decide to change directions that you have to think about it briefly. But otherwise, once you get it going, the spinal cord reflexes, and there's a brainstem center, the pedunculopontine nucleus, that sends the occasional impulse to keep the reflexes going in your spinal cord to say step, step, step. Okay, so that's mostly spinal level. You've seen like the Christopher Reeves or harness-supported treadmill training where they take somebody who's got a spinal cord injury, put them on a treadmill, and start moving your legs, and they start to walk. And it looks pretty normal. It's because they're tapping into these spinal cord reflexes that tend to, once your limb is in a certain position, you feel a stretch on your hip flexor, that signals you to take the next step, which then causes the other leg to push off, and this kind of complicated, very sophisticated reflex activity. But before we get to that, so at the spinal level, okay, so we're in the spinal cord region here, we have these things called myotomes, which these are groups of muscles at a spinal level that are primarily innervated by that one spinal level, okay? Primarily, not only. So like, for example, elbow flexion is primarily C5, but we know C6 is involved with that too, okay? Most muscles have more than one innervation because that's good, because if you lose one innervation, you still have some function of that muscle. But these are important to know. These are the primary spinal nerve that's influencing the motor activity of that particular muscle. But most of these have at least 2 levels of innervation. This is just the primary innervation, okay? And there's sometimes subject to controversy on these. But those are the ones that I think are the most important to know, which is the C5 to T1 and the L2 to S1. Because those are the things that go to your upper body and your lower body. It's hard to differentiate thoracic and lumbar stuff because you're talking about just little muscles and rib muscles and multifidi at those levels, and it's hard to evaluate those muscles specifically for a spinal nerve root problem, okay? Just showing you different cross sections through the spinal cord. This is at that cervical enlargement, and you can see how big the anterior horns are, because there's lots of anterior horn cells in there, because there's lots of little motor units that are firing all those forearm and hand muscles, okay? That's why it's bigger in that particular region. Here's the thoracic spine. The thoracic spine has very small anterior horn cells because there's not a lot of motor units. They're just going to big muscle fibers that fire grossly, like your postural muscles, okay? Not a lot of fine movement going on there, just gross flexion, extension, rotation of the trunk. and stabilization of the trunk. So you have a small number of motor neurons going to these larger motor pools or larger motor units. Okay. Down here we have pretty big anterior horns in the into the lumbar spine. Even though the motor units are fairly large, these are large muscles. You know, your glutes, your quads, your hams, those are large muscles. So there's still a fair number of anterior horn cells you need there to drive these large muscles. Even though the motor units are still pretty big, you just need a lot of those to drive these big muscles. And you have quite a few muscles down in your feet of your intrinsics and your lower leg that also require some, decent amount of control. The other thing in the thoracic spine, there's that little lateral horn that'll let you know that you're in the thoracic spine. And you can see this thoracic spine segment only has a fasciculus gracilis. So we know we're down mid or lower thoracic spine. We're below T6. There's no fasciculus cuneatus at that point. So motor neuron pools, I've mentioned them a few times already. Those are the axons from a motor neuron pool that all the axons that project to a muscle, okay, to one muscle. So all the axons from a motor pool that project to a muscle. We have, within the anterior horn, we have a medial pool, a lateral pool, an anterior pool, and a posterior pool. And medial pool axon or motor neurons tend to go to axial and proximal muscles. That makes sense. They're sitting in the medial part of the anterior horn. They go to medial proximal muscles. Where anterior horn cells that tend to sit more lateral in the anterior horn, they tend to go to more distal muscles. So that makes sense. And then the anterior horn cells, whether they're medial or lateral pool, or whether they go to medial or lateral muscles, the anterior horn cells that tend to be located more anteriorly in the anterior horn are going to more extensors, and then posteriorly more to flexors. So this is a good picture that shows kind of that arrangement. Obviously, one segment of a spinal cord is not influencing your entire upper extremity. But just thinking about that arm in that position of the anterior horn helps you give you a visual picture of how anterior horn cells tend to be located within the anterior horn. So if you have anterior horn cells sitting out here, these tend to be that's more lateral, these anterior horn cells, and they're more posterior at the same time. So these anterior horn cells are going to innervate more distal flexor muscles. Okay, so the anterior horn cells that tend to be located in this region of an anterior horn, anywhere in the spinal column, are probably going to be biased or more likely to be going to distal flexor type muscles, whether that's the upper extremity or whether that's the lower extremity. This is just showing, if you just remember that arm in there, this works the same for the lower body, but the lower body, it's hard to put the lower body in there the right orientation to get this picture in your head. So, but if you're purely, let's kind of divide this into, so here's more, if the motor neurons are located more posteriorly or dorsally, but we should put posterior, this is anterior, those tend to innervate more flexors, okay? The ones that are out here tend to do more distal function, flexors. The ones that are located in here tend to be more proximal function anterior horn cells of flexion, okay? Then if we go down here and divide it into kind of 4 regions here, if you're a motor neuron out this region of the spinal cord, you're probably innervating more distal muscles but more extensor muscles. In this case, extensors of the hand or wrist, elbow. If you're located in this region, there's a greater chance you're innervating more proximal extensors, more proximal extensor muscles of the shoulder, whatever, or the hip, hip extensors, those kind of things. It's not cut and dry, but that's generally where those tend to be more located as far as these motor neuron pools that go to muscles that drive those functions. This is another representation of that too. So just showing you where the motor neuron pools are located that go to flexors and extensors and more proximal and distal locations. So that's kind of how they're showing and representing that for both the upper and lower body. This is kind of a nice shot here. So when we start talking about the descending pathways, this will make a lot of sense. The descending pathways, like the lateral cortical spinal tract and the rubrospinal tract coming down, they come right down in this region. They are going to communicate with more distal flexor muscles. Those are the flexor bias tracts, so the lateral activating system that we'll talk about, rubrospinal and lateral cortical spinal primarily. We'll talk about one other one. But those tend to innervate distal flexor muscles of the legs and arm, okay? And then the medial activating system, those pathways run down through here, and they run down through this anterior funiculus here. They are communicating, or they are close to, they're more close to this anterior motor neuron pool, which tends to bias extension. So when we start talking about that medial activation system pathways, the majority of those bias extension of our body. The lateral activation bias flexion to our body, okay? If you think about it, our extension movements are usually pretty gross postural types of movements, standing up against gravity and not falling over, basically, and maintaining an erect position of our body, where flexor stuff is where you tend to do more fine manipulative kind of things with your foot, ankle, toes, hands, fingers. So those are the flexor bias tracts. But that's why those motor neurons are located in those regions, because they're closer then to the pathways that are carrying mostly extensor information or flexor information. So they're regionally located there. Get through a couple more things and we'll take a break. Spinal region coordination. So some of the things that happen at the spinal level to help just coordinate movement, things like muscle synergies. So there's a synergy pattern called the flexion synergy pattern, like this. When we bring something to our mouth or our hand to our head to comb our hair, brush our teeth, feed ourselves, there's a group of muscles that work together. Once you send a signal down to a muscle or two, the muscles in that a couple levels above and below in the spinal cord start to recognize, hey, you're sending it to these muscles, I better contract too, because I'm sensing a synergy here. So, or even like throwing a ball where you throw it and you come this way and down across your body, or when you pull something like a sword or you bring something up, that's a synergy pattern too. And so there's certain synergy patterns that we commonly do, but once you get them going, the spinal cord actually helps to assist that synergy. And that's through interneurons and communication at a few levels between the upper body, like cervical segments, when you're trying to use your arm in a synergistic pattern, okay? Synergies are normal. All of us use synergies. They become abnormal when you can't control them or you can't move away from the synergy. So, for example, when somebody has a stroke up in their brain, and we'll talk about why this occurs, but you ask them to lift their arm overhead, and if you say, lift your arm straight up over your head, keep your elbow straight, keep your wrist straight, lift your arm up over their head. They'll go, okay. And they'll try to lift their arm up, but you're going, no, you're bending your elbow, you're bending your wrist, you're supinating, you're abducting. That's not what I want. I want this. Well, they're tapping into the synergy pattern that we normally have, but they can't move out of it. Normal people can move in or out of synergy. I'll use my synergy when it's appropriate, but I can move out of it when I don't want to, because this is out of synergy. This is keeping my elbow extended while I flex my shoulder. The normal synergy is flexion of the shoulder, flexion. But this person with a stroke, when they have damage to higher centers, then their spinal cord coordination gets impaired. You need some control from higher centers to keep your spinal level control appropriately active or not active for the task, okay? So just keep that in the back of your head right now. We have things like stepping pattern generators, which involve synergies, but for the lower body. And it's this, once you get your legs going and stepping, they tend to keep going. This involves some reverberating circuits, some actually where axons go back to themselves to keep themselves going once they've been initiated. But you're getting these stretch reflexes of the hip, the ankle, the gastroc, and that signals the next step and the next step, and you're weight bearing because you're getting proprioceptive input that tells you you're against gravity and you're pushing off the floor, and that helps those synergy patterns to kind of fire at the spinal cord level. They're called central pattern generators. We have basic reflexes. Tap on your tendon and cause a reflex. That's a spinal cord level thing. Reciprocal inhibition. When I flex my elbow, I inhibit my tricep because I don't want my tricep to get in the way of my elbow flexion. That's a reciprocal inhibition. That's a spinal cord level coordination that occurs there. That happens at the spinal level. We'll go through these real quick. So reciprocal inhibition, here you are sending, this is a muscle spindle. You're sending a signal to, so here's your alpha motor neuron. You're extending the knee. So you're turning the quad on. The muscle spindle senses that you're turning the quad on. And that it's shortening. So a signal goes back through the 1A afferent from the muscle spindle, directly back to through the dorsal horn and the dorsal root and dorsal horn. And it synapses both on the anterior horn cell to actually increase the motor output of the quad. It's self-fulfilling or self-exciting, but then it has a collateral that goes to an inhibitory interneuron that sends a signal to the hamstring to tell it to downregulate and turn off so that it doesn't interfere. Now they're showing this happening at one particular spinal cord level. That's not happening. Your quad, is L2, 3, 4 region. Your hamstrings are S2, S1, S2 region. So there's actually a signal that goes up and down that Lasauer's tract in the back to tell. So it's just trying to simplify the representation here. But that's what's occurring, is that but this happens at a couple different levels in the spinal cord. So your quads are turning on, and they self-stimulate through that reflex, but then they also turn off your hamstrings. That's the reciprocal inhibition. Basic reflexes. At one time, scientists thought all movement in the body was reflex in nature. Okay, so and that basically all movements were just a chain of reflexes. Okay, and so when we talk about motor learning and motor control, we'll give you some examples of that in nature that they kind of. But we know that almost all movements we do are a mix. They're a combination of voluntary but influenced by reflexive movement as well. Okay, so we have usually some combination of reflex and voluntary movement, unless you're you're telling the person just sit there and tapping on their tendon. That's pretty pure reflex. But everything else that we do in life involves some combination of, once you start moving and you voluntarily choose to do something, then you're getting sensory input that drives reflex kind of overlay and modifications. Okay. But a reflex examination can give you some very basic idea of the integrity of just well, it tells you about the sensory nerve, because it has to go, when you tap on the tendon, the signal has to get back to the spinal cord first. And then it also tells you about the motor nerve that has to go back to the muscle. But it doesn't tell you what the problem is. If you have low reflexes, you just know there's a problem with the peripheral nervous system. If you have high reflexes, then you know there's something wrong with the descending pathways that go down to moderate our reflexes to keep them at the appropriate level. We have our descending pathways in higher centers help keep our spinal region reflexes and synergies acting appropriately for the situation. So low reflexes means peripheral nerve problem. The signal is either not getting back to the spinal cord, or it's not getting out from the spinal cord back to the muscle. High reflexes than you'd expect on one side versus another is an upper motor. It's a problem with the descending pathways. The circuit's intact at the spinal cord level. It's just something that's from above that's not keeping it moderated at the right level. Yep. It can, yeah. So that initial rep, you get a quick stretch until your muscle kind of contracts, but then it self-generates, or it's I think I have the term coming up here, but it's facilitatory to the agonist. When you're contracting a muscle and stimulating the muscle spindle, it's facilitatory to the muscle it's embedded in. It's facilitatory to the agonist muscle that's embedded in. And that's the reason why so when you contract a muscle and it's shortening, the muscle spindle shortens with it, and you do get an increase in the amplitude of the signal from the muscle spindle that tells you to make the muscle fire more. That's a concentric shortening contraction. However, you can generate more force in an eccentric contraction because you're lengthening the muscle spindle, and you actually get an even increased level of signal enhancement from the muscle spindle. So you can generate more force, and that's why you get so dang sore from eccentric contractions. You can actually create more muscle failure and a stronger contraction out of the muscle, plus you're lengthening the muscle, so that's even making the micro tears and trauma even more, but it's also that you're able to generate more force because the muscle spindle is more facilitatory back to the agonist because it's being lengthened. When it's shortened, it's shortening. It sends a little bit of a signal, but remember, it kind of wants to turn down unless you have that good alpha gamma coactivation. That's another reason why alpha gamma coactivation is so important. When a muscle's shortening and you're actively trying to generate contraction, you got to keep that thing shortening with it, so keep sending signals back to it. Okay, that's why when you do it passively and you shorten a muscle passively, you don't get. That's why they're trying to like trick the muscle spindle to turn it down or down-regulate the muscle spindle. So you guys all know about the stretch reflex. So this is the myotactic reflex, stretch reflex, or deep tendon reflex, DTR. All those are interchangeable. This is the classic monosynaptic. It involves just one single synapse. Here's the leg. You tap on the tendon. That creates a quick stretch of the quad. Muscle spindle sends a signal back via the 1A afferent directly to the dorsal root into the dorsal horn, and then one synapse back onto an alpha motor neuron to the motors. Then it goes out through the alpha axon to the muscle and creates a contraction due to that quick stretch. Autogenic facilitation, that's the word I was looking for, facilitates the muscle it's embedded in, so this autogenic facilitation. That quick stretch lengthening is more facilitatory than when you're contracting it and shortening it. Even though that still does create some autogenic facilitation, it's not as strong because the muscle spindle is shortening. It's trying to keep up with that shortening and still maintain a stretch to it, but there's tension going on in the muscle. The GTO also helps contribute to this too. So it's not just muscle spindle, but when you're doing a concentric contraction, tension is increasing, and the GTO will help go back and facilitate the muscle as well, to a point. This is what we mean by the phasic stretch reflex. Quick, turns on, the muscle contracts, and it's done. There's also a tonic stretch reflex that normally is not present if you have a normal nervous system. It's only when you have those descending pathways coming from the brain and the brainstem, if they've been damaged and they're no longer doing their job to influence the activity at the spinal cord level, we have what's called a tonic reflex. And that's where you take somebody's leg who has a stroke and you move it, and you get resistance all the way through the motion, not with just a quick stretch. You may also get that. You tap on their tendon, it's like boing. They've got high reflexes, but then you lift their leg up and you feel resistance now through the entire movement, because as long as you're moving that muscle spindle, it's creating autogenic facilitation. Normally, in a normal nervous system, we inhibit that tonic portion of that because we want to be able to move our limbs quickly and move them, turn muscles on and off quickly. We don't want to keep them on the whole time that you're moving something passively. And so this tonic stretch reflex is something that is abnormal if it's present, and when you're trying to move somebody's limb who's got an upper motor neuron or neurologic disorder. I think we need a break. so I need my voice needs a break too. So, all right. So, any questions? Of what, Christy, real quick.
What you were just explaining, so the brain and the brainstem isn't sending like those gamma.
Not gamma. So when you're sending via your descending motor pathways, whether it's your lateral cortical spinal tract, rubospinal tract, all those medial activating pathways, they all go down together and they influence all the motor neuron pools throughout your spinal cord. And they're falling on interneurons, they're falling directly on alpha motor neurons. And when your system's working normally, there's a certain level of just baseline activity of the alpha motor neurons at all times. And there's a certain level of sensitivity of reflexes and so forth. When you start to damage those descending pathways, you start to lose some of that control, and you get to see these abnormal expressions of reflexes, like overactive reflexes or underactive reflexes or inappropriate synergy patterns. So once you start damaging these you need the descending pathways working properly to maintain kind of a order or control over the spinal cord reflexes and synergies and those kind of things. Once you start damaging those, you start seeing these unique expressions of abnormal reflexes and abnormal synergies. Does that make sense?
Kind of, but I don't understand why it would be like resisting. Like with the tonic piece, when it moves, when you try to move it, it like resists. Like why would it resist?
Well, so normally when you do a quick stretch on a muscle, a quick stretch on a muscle means that, like the reason why you have that, one of the reasons you have myosynaptic reflex is, let's say I'm standing here and my body sways forward and my gastroc stretches quickly and then it pulls me back. And that's how I maintain postural control without thinking about it. Normally we don't have that much air in our system, but, or let's say I go to step off a step and it's higher than I expected. And all of a sudden, I didn't have my muscle turned on ahead of time where I thought, and all of a sudden my knee starts flexing rapidly, and because it was a larger force demand. And all of a sudden, so that tells the muscle spindle, turn on really hard and really fast so my knee doesn't collapse. So that's kind of the reason why reflexes. But if I'm just sitting there and I want to relax and just let somebody move my limb, the muscle spindle should turn off, knowing the situation it's in, because of the descending control says, aha, I should be here relaxing, and when somebody moves my leg, my muscle spindle should be down regulated now because I'm laying on my back, I'm not in a weight bearing position, somebody's just lifting my leg and moving it, so I'm going to turn the muscle spindle sensitivity down so that it doesn't resist that movement. But a patient who's got a problem with those descending control pathways can't do that. And so you lift their leg and you tell them to relax, and then as long as their muscle spindle starts getting stretched, it says, oh crap, I'm getting stretched, turn on muscle, even though it's not appropriate for the situation. Does that help, Christy? Okay. All right, break time. Come back in 10. Now. Do I need to say all that over again? Yeah, got it. So it works with other proprioceptors, the GTO. The GTO, we used to think, initially it was, was supposed that it was a protective mechanism, that it sensed tension, then once the tension got too high, it turned off your muscle to protect it. It doesn't work that way. It can turn on or turn off depending on the task, depending on all the other influences of the muscle spindle and so forth. It tries to adjust your body to what it needs at the given moment, and it does have a protective aspect to it in the sense that it tries to distribute the load over the musculotendinous junction more evenly, is one of the roles it can play. So this is showing you like that role, that dividing the tension across the musculotendinous junction. So here's a muscle that's been pulled out on its own, and it's being stretched or tension. Here's the weight down here pulling on this muscle. These are all alpha motor neurons, okay, that are going to that muscle as if it was contracting, or there's tension in that muscle. That muscle is contracting to overcome the tension of that force or that weight on it. So it's trying to hold that weight. Here's our GTOs that are located in the musculotendinous junction. So it can act in both facilitatory or an inhibitory way. So maybe what happens is this particular anterior horn cell and this particular region of the muscle is getting too much tension. So the GTO in this case is going to communicate with an inhibitory interneuron to tell this anterior horn cell, hey, turn yourself down a little bit, while these other two sense that, hey, we're not doing these parts of the muscle aren't quite doing their full share. We'll go back to the dorsal horn and we'll communicate with some excitatory interneurons that tell our gamma motor neurons here, not alpha motor neurons, sorry, to turn up the signal to those. And what happens is you turn this guy down a little bit, you turn these up a little bit, but then now they all kind of even out. So you even the tension across the tendons, so they're all doing their fair share of their work, and not one part of the tendon might get torn or, damaged. Okay, so that's kind of one role of the GTO, that it goes back and senses that tension and adjusts the level of motor output of the different motor fibers that are attaching there so that it evens it out. Oh, the other thing is I mentioned is, so for example, it may facilitate or inhibit depending on the task. Let's talk about stance versus swing. So if I have some GTOs in my gastroc at the musculotendinous junction of my Achilles tendon there, okay, and I'm in a weight-bearing position. I'm in my stance position getting ready to push off. So not only does my muscle spindle getting a decent stretch here, and there's tension in the there's the muscle spindle and the muscles lengthened and the muscles turned on, so that isn't facilitatory back to the muscle through the muscle spindle, right? And that's turning that on ready for push off, right? Because you're going to push off the ground here. But the GTO senses you're in a weight-bearing position, because it's also going up to the spinal cord level. It's getting information from the bottom of the ball of your foot to say, you're in a weight-bearing position. So now as a GTO, I'm going to make sure that I'm sensing tension on the tendon, and I'm in a weight-bearing position. I'm going to send a signal back to the muscles, knowing I'm in a stance position and ready for push-off, to enhance even what the muscle spindle's doing. Okay, so I'm going to go ahead and help push off. Unless you get across a critical threshold where there's too much tension and you're going to tear that Achilles tendon, then the GTO might try to downregulate. But under normal circumstances of normal gait and walking, during weight bearing, the GTO facilitates the muscle during weight bearing during stance phase, especially the gastroc is one. So it can change its role. But then when you lift your foot off the ground and you take the tension off, the muscle spindle and the GTO both are inhibitory to say, all right, no longer are you in weight bearing, turn that gastroc off, because you're going to have to turn on the anterior tib pretty soon. And then through reciprocal inhibition as well, we're going to also inhibit the gastroc through reciprocal inhibition, but also the GTO muscle spindle are no longer on stretch, and since they're no longer in weight bearing, so turn that gastroc off, turn on dorsiflexors, ready for swing phase, okay? So the role of these sensors can change based on the task. We also have these things called cutaneous reflexes, and you may have learned about some of these in peds or development. We have a thing called the flexor withdrawal reflex. So the flexor withdrawal reflex is where you have some noxious stimulus to the surface of your skin. And the classic example of this is the bottom of your foot. Somebody tickles your foot, or you step on a pin or nail or something like that, and it gets those cutaneous free nerve endings, you get a pain signal, and you do this. And it's this stereotypical flexor withdrawal response. And oftentimes it also involves a cross extension. So if I am standing and I step on a sharp nail, I have to flex this leg really fast, but I got to extend this leg really hard to make sure I don't fall over. That's the cross extension. However, if I'm laying down and somebody just tickles the bottom of my foot, my body knows I'm not in a weight-bearing position, so it'll just do the pure flexor withdrawal, but I won't get the extension on the other side, because I don't have proprioceptive input coming from the ball of my foot telling I'm in weight-bearing. So if you're in weight-bearing, you get the cross extension. If you're not, you just get the pure flexor withdrawal. And you can see that involves multiple levels of the spinal cord, and that's why, so in this picture, here is the free nerve ending. This is an A delta fiber, right? Sensory fiber, axon. Goes up into the spinal dorsal root, into the spinal cord. However, remember that little dorsal lateral tractile Lissauer? I said especially pain signals, often go up and down a few segments before they make that connection. So part of the reason you have that dorsolateral tractylus is so you can send signals to multiple levels to innervate for this flexor withdrawal response multiple muscle groups, so both hip flexors and knee flexors at the same time. And that's going to create that flexor withdrawal response.
The flexor withdrawal reflex, is that kind of like, is that like a reason why you might jump during a scary movie? Just, or is it not at all? You're anticipating something, but it's kind of like.
It's not, you know, this is purely has to be driven by a stimulus to the skin. I think what you're doing there, it's more of a primitive, we still have some primitive reflexes that are buried that we keep under control, but in certain situations that come out. I think the jump is more of a Moro reflex, actually. Like, whoa, and you just get this Moro reflex type of thing. So, yeah, but good. There's actually, people have that who have like cerebral palsy where their body fully extends to like a loud sound or something scary, or you drop the oxygen tank in the clinic, or somebody makes a loud sound, and they extend and they literally launch themselves out of their wheelchairs because it's such a strong extension response, and they go boom, and they're just like out of the chair. That's why they got to have their seatbelts on, you know, like keep that seatbelt on. So we talked about the flexor withdrawal. This is a multisynaptic, so it involves synapses at multiple levels, okay, of the spinal cord to drive that reflex. Then the cross extension is just that you actually communicate with the other side of your spinal cord and tell the other limb to extend. This works for the upper body too. We have a flexor withdrawal with our hand, but if I'm like in weight bearing doing push-ups and then I put my hand on a rock and I pull it up, I got to make sure I extend the other arm to hold myself up. So we can have a cross extension, not just the legs, but you can do this in the arms. Something simple is like there's the abdominal reflex where you scrape the abdominal region and it's perceived as noxious, and you contract your muscle to kind of like try to get away from that. And you'll see the umbilicus deviate towards the side of where you did the stimulus, because you're contracting that one side. So you take your reflex hammer and you scrape up the rectus abdominis on each side and see if it deviates, because it's perceived as it's wanting to protect your gut, you know, because it's perceiving that as something's going to stab me or something, and I need to tighten that muscle in preparation for something to do that, on just the one side. Then we also have a thing called the plantar reflex, or the Babinski reflex. So this is where you scrape the bottom of the foot. Normally, you should not have a Babinski reflex. If you have a Babinski reflex, that's abnormal. So, but we test for the Babinski reflex by scraping the bottom of the foot up the lateral border and underneath the metatarsal heads. You kind of take your reflex hammer. We'll try this in a little quick lab experience. You scrape up underneath the bottom of the metatarsal heads and along the lateral border of the foot in about a 1/1000. It's not supposed to be painful, but it's supposed to feel kind of not comfortable necessarily. And typically, normal nervous systems actually point the toes and like push it away a little bit. Although unless somebody has a really sensitive tickle response, and then they might flexor withdrawal. But most people, if you get it in there firmly and do this without tickling them first, sometimes it's hard. Some people are impossible to test this on. They're just they got too high of a set of fear, anxiety, and tickle to let you do this. But most people, you just get in there, if you don't make a big deal about it, you just kind of scrape it before they even know what happened. And normally what happens is your foot flexes, your big toe points down, and your other four toes tend to come together and point a little bit too. It's like a little bit of a wink, you know, just like your toes just do that. If it's abnormal, what happens is your big toe extends and your little toes, your other four toes flare out. And that's an abnormal response if you're an adult. If you're older than a few months old, then that's an abnormal response. It's actually normal in a child up to about 3 to 6 months because they're still myelinating the nervous system. So all a Babinski reflex tells you, if you scrape somebody's foot, that means there's some problem with the descending motor pathways. It means there's an upper motor neuron problem. There's something wrong in the cerebrum, brainstem, or spinal cord that involves the motor pathways. That's all that tells you. The H reflex is simply the electrical equivalent of the stretch reflex. It's how you can initiate this in a laboratory and then measure it. You can actually measure the response of the H reflex. Okay, can be used to quantify basically the excitability of your alpha motor nerves. Okay, the excitability of that monosynaptic stretch reflex. So what they do is they have a stimulating electrode that's most often done in the lower extremity. They put it behind the popliteal fossa, and get the sciatic nerve essentially. They have a recording electrode down here, farther distally. So the electrodiagnostician or a lot of times it's a physiatrist that does this testing, but there are physical therapists who are trained and get certified to do this type of testing. You send a signal, stimulate that stimulating electrode to the nerve. A signal is sent both ways. You stimulate the middle of the nerve and you get an action potential going both ways if you stimulate the middle of the nerve, right? So you stimulate the middle of the nerve, an action potential goes this way via the sensory fibers, and an action potential goes this way on the motor fibers, okay? And so those go down to this recording electrode, picks up that initial volley or that initial stimulus, okay? That initial stimulus is called the M wave. That's this going down, and that's just the electrical signal. You don't really care about the M wave. Now this signal that was sent up the afferent sensory neurons goes into the spinal cord and then sends a signal through the monosynaptic reflex, the same as the stretch reflex, back to the alpha motor neuron, and it goes all the way back down. And when it gets back down to that recording electrode again, and you get the twitch response, muscle response, that's called the H reflex. That's what you're looking for. You're looking for the actual height of this in millivolts, that response that you're getting from that muscle. And that tells you how excitable that muscle is. So somebody with a spinal cord injury will have a higher H reflex because it tells you about how excitable that stretch reflex is. Because they're no longer, so a spinal cord injury, if you're damaged, the control coming from higher above, that stretch reflex can just work without any moderation or influence from higher centers. So it works just like full tilt. Okay, so people with spinal cord injuries especially, with a stroke, you still have some descending input. When you have a spinal cord injury, there's nothing. And those reflexes, you type on their tendon, it just boom, or you see them get like a clonus going, it just doesn't stop because those reflexes are so high. So you see that H reflex really high on them. Somebody who has a peripheral nerve problem, like neuropathy, the H reflex is real low because the nerve, the actual peripheral nerve is damaged. So the signal doesn't get up. There's usually not a strong signal that gets back to the spinal cord, and the signal is also diminished coming out if that nerve is damaged or has neuropathy, or the nerve down here is slower, usually more distally is where you see that. But no matter where it's slow, it slows the signal and dampens the signal, so the H reflex is lower. And they've done studies to show, like, for example, through physical therapy, like somebody has a spinal cord injury, they'll test the H reflex, and then they'll do, like, say, an FES bike and make them pedal on a bike with, not voluntarily, but with electrical stimulation, or doing weight bearing or walking on a treadmill. You can dampen the H reflex and lower it just through putting proprioceptive input and making people move more normally. You can get some moderation of the H reflex with physical activity. Doesn't make it perfect. They still have too high reflexes, but it can make it a little better. So. But it doesn't tell us about function. Just because you have a lower H reflex or higher doesn't really tell us about whether that's going to impact your function or not. Any questions on some of that? Spinal level, motor control, spinal level. All right, now we get to go pathways. So now we're going to talk about all the descending pathways that are going down to those spinal regions to influence voluntary motor output, but also modulate the reflex activity a little bit too, okay? Those are the descending motor pathways. So we are going to start with what's called the medial activation system, okay? Think about this as your posture and gross movement systems. These tend to be a little more automatic in nature. The background muscle activity that occurs to maintain postural positions, your position of your body against gravity, your just kind of natural tonal set of your muscles, that appropriate level of activation between flexors and extensors in our body. Okay, we want to have at all times kind of this optimal balance that's ready for a task. So I don't want all my extensors turned on too much. I don't want all my flexors turned. I want some balance between them, and then so that I'm ready to do whatever task that presents. And the medial activation system, as a rule or as a general, it promotes background extension of most, not all the time, but we'll talk about a few exceptions, but it tends to turn on postural and gross movement muscles and tends to bias extension, okay, against gravity. You know that it's more primitive in nature just because that 4 of its tracks begin in the brainstem. So brainstem level control is not as sophisticated as cerebral control. But it does have one track that does begin in the cortex, but 4 of the 5 are brainstem tracks. So these are the major pathways of the medial activation system. There are some discrepancies in the textbooks and the literature you will read on what these are called. This is what matches up with your textbook, and it matches up with both of your textbooks. So some people will call this tectospinal tract the MLF, and we'll talk about the MLF in a second, the medial longitudinal fasciculus. Some books will call that pathway, no matter where they're talking about it, in the brainstem or in the spinal cord, they'll call it the MLF the whole way. But we're going to talk about it as the tectospinal tract, at least in the spinal cord, but we'll get there. So we have the medial cortical spinal tract, the lateral vestibulospinal tract, the medial vestibulospinal tract, the tectospinal tract, and then the pontine or medial reticulospinal tract. It's nice here that at least medial help you think medial. However, you have this guy here that's the exception, the lateral vestibular. I hate that. It's like, come on, can't we just have that be a medial vestibulospinal tract? Because you actually see the medial vestibulospinal tract actually is part of the lateral activating system, so like crap. But this is another good picture. This is the picture out of your Crossman book. This is a picture that shows the spinal cord and kind of in 3 dimensions, the various white matter pathways that are traveling through your spinal cord. On the left, this is all sensory pathways. On the right is all the motor pathways. But you can kind of see how everything fits in there because you can still see the little highlighted regions of where the motor pathways are running, okay? I'm gonna circle all these pathways right here that run down the spinal cord. Yeah.
On the slide before, you said that the tectospinal had the medial longitudinal fasciculus. Why is the medial vestibulospinal?
Good question. There is some, so when we get to those slides, I'll confirm for you, but I think there's actually some times that, so the medial vestibulospinal tract and the tectospinal tract in the brainstem are often running both in the medial longitudinal fasciculus before they, but I want to confirm that when we get to the slide, and now I'm going, am I questioning myself here? But so good point there, good pickup there. So the ones I circled here, these 5 right here, are all associated with the medial activation system. You notice they're kind of sitting more medial. They're closer to the anterior horn cells that are part of that medial activation pool. These are also more extensor bias tracks, okay? These 3 tracks right here are your lateral activating system. Lateral activating system. Even though this guy's sitting up not quite lateral, but those 3 are grouped together as lateral activating pathways. 2 of these pathways the medial vestibulospinal tract and the tectospinal tract. This guy, let me erase some of this stuff. So this guy and tectospinal, this guy, these are only present in the cervical spine. They go away once you get down to the thoracic spine because they only innervate neck and upper body proximal muscles of the neck and cervical spine region. Then they're done. And then, so when you get down into the thoracic and lumbar spine, you won't see those guys anymore. You'll just see these three right here that go all the way down to the lumbar spine. So all I'm saying is you'll see some cross sections, and if they show a cross section through a thoracic spine or a lumbar spine and they don't show these two, you'll know why. Okay? It's because they've ended. They're done. So we are going to go and talk through each of these pathways. Your Ekman book has a very kind of diagrammatic approach to this, but I wanted you to see it more, you know, in these anatomical sections and so forth. So these are from your Crossman book, okay? So the Crossman book is where I took most of these pictures from, although I had to supplement it with a few other pictures from another book because your Crossman book doesn't fully go to all, doesn't go into detail on all these pathways, so I had to supplement. But this one's from your Crossman book. So the first medial activating descending pathway is the medial, also called the anterior corticospinal tract. And let's break down the words here. It's medial or anterior, so we know it's probably running in the medial or anterior part of the spinal cord. It's corticospinal, so we know it started in the cortex, and it's ending up in the spinal cord. So it started, that helps us know it's corticospinal, and it's probably running more medially or anterior in the spinal cord based on just the terminology and name. Okay? Primary function. Primary function of this medial corticospinal tract is it innervates and controls axial and proximal joint control, especially of the neck, shoulder, and trunk. Doesn't do much to the lower extremities and lower body, you know, because it's axial, proximal. So shoulders, trunk muscles, and neck innervation. It begins in the cortex in the areas called Brodmann's numbers 4 and 6. And we get to that, we'll show you the cortex areas, and there's a number system that's used to describe locations on the cortex, and then there's also just what the name of that region is, and we'll cover that in a little bit here. This is how it descends from its location. So this is more upper body, this is more lower body, okay? This particular picture is showing both the lateral corticospinal and the medial corticospinal pathways together and where they separate, okay? So let's talk about these. They all start, if they're coming from the cortex, they start in the cortex, and they all go down through this region here. This little region here, before they get real close together, is called the corona radiata. So all these axons are flaring out to go to different regions, and it looks like the rays of the sun. Corona radiata, it's the radiating rays of the sun, kind of like, so all these axons are going and spreading out to these locations along the cortex. So that's called the corona radiata. So they're traveling on the corona radiata, but then they get into this little narrowed area between the basal ganglia and the thalamus area, and that is the internal capsule. That's what's next. So it goes down through the internal capsule. Then they run down this front part of the midbrain. So this region right here is called the crus cerebri. But if you're looking at the outside of that midbrain area, that's the cerebellar peduncle. When you look at, that's what you call it when you're looking at the outside surface of it. But when you're looking at it in cross-section like this, it's the crus cerebri. So that is the crus cerebri, is this area right here. Then it runs down through just this region called the ventral pons, or the basilar pons. So ventral or basilar pons. That's that front part of the pons. So you're seeing motor system running down right now that front part of the brainstem, where sensory stuff, remember, tends to be more towards the back of the brainstem. So that's sort of a general rule. Doesn't always work out perfectly that way, but front part of the brainstem tends to be more motor. Back part of the brainstem tends to be a little more sensory in nature when we're talking descending and ascending pathways. Then it becomes the medial and anterior cortical spinal tract at the level of the medulla. So here's the medulla. These are the pyramids. Runs down through the pyramids. So after you get through the front of the pons, you're down on the medulla and you get into the pyramids. Okay. The nice part is the pyramids are called that whether you're seeing a cross section of them or whether you're seeing the front of that medulla. You call it the pyramids no matter what. Where up here in the midbrain, it's called the crus cerebri from the cross section. It's called the cerebral peduncle from the front view, external surface of it. Once it goes down the pyramids, many of these fibers and axons cross over to become your lateral cortical spinal tract. But right now, we're doing the medial. So it's the fibers, it's the 15% or so of fibers that don't cross over, that stay going down that same side and stay anterior and medial in the spinal cord, that are called your medial or anterior cortical spinal tract. Okay, so let me erase some of the stuff here. So right here, this is the crossing point. That's called the decussation of the pyramids. So it's the fibers that are staying on the same side initially, running down that anterior and medial part of the spinal cord in both the cervical, less so in the lumbar, but there's some that make it down to the lumbar. That's the anterior cortical spinal tract. Most of those fibers cross back over now, or cross over at the level of the spinal cord where they come down, okay? Most, not all. There's actually some ipsilateral connections, but as a general rule, most of those cross back over in that anterior white commissure. That anterior white commissure is also the crossing point of our spinothalamic tract, or spinothalamic system crosses over before it becomes our spinothalamic tract, but it's also it's a crossing point for this motor, anterior medial motor pathway. However, I will tell you, many textbooks won't even show this crossing back over. They will tell you it's an ipsilateral tract, but it's really not. It's really still a contralateral pathway for the most part. So if you see that again, so it comes down and then it crosses over to terminate at its appropriate level. But it does have a few ipsilateral connections. It's not purely contralateral, it's mostly contralateral. But some textbooks will not mention, they'll just say the medial and anterior cortical spinal tract stays ipsilateral. It does in a sense, but then when it terminates at its different levels of the spinal cord, it crosses back over. And so it really truly is more of a contralateral tract, but it has some ipsilateral connections. The lateral cortical spinal tract, which we'll get to after we get through these, is purely contralateral. It only has contralateral connections, but this medial anterior cortical spinal tract has a few ipsilateral. It's mainly contralateral, but it has a few ipsilateral / bilateral connections. Part of that is because your postural muscles, and you'll see this when we get to some more of these medial activating pathways, you tend to fire postural muscles symmetrically on both sides of your body, and they're really close to each other, right? So when you're trying to fire just one limb or one finger, one arm, it's way out here, it's different. You're not firing your arms. Well, you do sometimes fire them together when you're doing manipulating, but you're using your arms very differently. But postural muscles tend to work together and tend to stabilize parts of or create gross movements of your spine, and they work together. So they tend to have more bilateral, sometimes ipsilateral. They're not as purely contralateral as the lateral activating pathways are. It says that it ends in the mid-thoracic region, but you'll see this picture shows it actually going down to the lumbar cord. There may be a few of them get down to the lumbar, but it mostly ends in that thoracic region. This medial cortical spinal tract is mainly cervical and mid-trunk region. But don't get hung. I won't ask a question about that. So that's the medial cortical spinal tract. So let's just show you a few, reference a few of these areas and show you on some cross sections, because we're going to see this consistently now. And anytime we talk about something from the cortex, we're going to go through these same areas. So this is the motor areas of the brain on the cortex. So the area 4, that's the primary motor strip. That's that precentral gyrus, right? Central sulcus is right here. It's the precentral gyrus. That's the primary motor strip. Area 6, Brodmann's areas number 6, encompasses both two named areas. This area up here is the supplementary motor area, and then this area just below the supplementary motor area, but right in front of the primary motor area, is the premotor area. Area number 6, which includes supplementary and premotor, those are motor planning areas. Those are areas of your motor system on the cortex that have a lot of pre-planned common movements we do, or movements that involve bimanual tasks of both our limbs working together. The primary motor strip is where the discrete individual signals are sent from the cortex down to the individual muscles. The premotor areas are more like some stored programs that will send their signals over to the primary motor area or down to the basal ganglia first, then the basal ganglia goes back up to the primary motor area to release the signals to the individual muscles. So that's all you need to know for now. This is a mid-horizontal section through the brain, okay? We're looking down, cut the brain in a horizontal section, it's actually slightly oblique, but this is the, so you can see here's the cut. It's slightly oblique here, but it's pretty much right through the middle of the cerebrum here, and we're looking straight down on top of it, okay? And this is where the VR stuff would help you. If you go in and start playing with some of the VR to reinforce what you're seeing here, that could be helpful. So let's point out some structures here. You're not ready for this yet, but this is basal ganglia structures. This is a basal ganglia structure. There's a little guy back here, a basal ganglia structure. But then this is your thalamus here and your thalamus here, okay? So we're just going to say thalamus. We're just going to right now just call this basal ganglia. We won't get into the details there. But between the basal ganglia structures and the thalamus is this region. This white matter region or zone. That's the internal capsule. That's where all the stuff gets squeezed down in between the thalamus and the basal ganglia structures into this called internal capsule. We divide the internal capsule into, this is the posterior limb of the internal capsule, and then there's an anterior limb of the internal capsule. All the motor and sensory stuff runs in the posterior limb of the internal capsule, and they're right near each other. They're kind of right in this region, right in here. Motor and sensory are all right there. So if you have a little stroke right there, you can wipe out all your motor and sensory pathways because they're all really close to each other there before they start spreading out to go to the different regions of the cerebrum. Okay? So this is a representation showing, this is from Netter, showing the different, this is the homunculus here. So this is homunculus, this is the body laid out, this is over the motor strip, this is not the sensory, this is the motor strip. And so you see, this is the corona radiata, that's all this stuff from the different regions of your body. They all get squeezed down into the posterior limb of the internal capsule. They all go down the front part of the brainstem, starting in the midbrain. They're in the crus cerebri. Then they're in the front of the pons. Then they cross over if they're going to go to the lateral cortical spinal tract, or they stay on the same side if they're going to become part of the anterior medial cortical spinal tract. These are all the motor fibers coming from face, hand, trunk, leg. You'll notice that some of these fibers stop off to innervate cranial nerve nuclei. That's for the face. Those are called the cortical bulbar tracts. Your bulb is your brainstem. So this is kind of like that, like in the anterolateral system, you know, where all those sensory pain and temperature pathways are coming up and they're just stopping off at different points, and that's how you determine what they are. It's kind of the same thing with all the motor fibers coming from the cortex. So any motor fiber coming from the cortex, you determine what it's going to eventually, they all start off in the same way. They all start off the corona radiata, internal capsule, crus cerebri, basilar pons, but some start stopping off at and innervate cranial nerve, motor nuclei of cranial nerves, and those are called cortical bulbar tracts. Or they all cross over at the medulla and go out down and become the lateral cortical spinal tract, or they stay on the same side initially and are called the medial cortical spinal tract. Make sense? This is showing you, this is posterior, this is anterior, this is the thalamus right here. These are parts of the basal ganglia. This is actually the posterior limb of the internal capsule. All of the red here, that's all motor fibers right there, right near what's called the genu of the internal capsule, right near the bend of that. Just behind it, that's all the sensory stuff is right there, just behind it, just posterior to it. Now we're looking at a coronal section, a mid-coronal section through the cerebrum here. So this is all corona radiata. If this coronal section is through the precentral gyrus, through the motor strip, well, that's what we're going to assume. That's probably pretty close. This is all the regions of your cerebrum up here associated with that, of the cortex. These are all the corona radiata fibers coming down. Then they get squeezed down here. This is the internal capsule, and this happens to be a cross-section through the posterior limb of the internal capsule. However, it'd be hard for you to know that unless you knew a little bit more about internal anatomy, and you won't need to worry about that for this class to be able to discern if you're in the anterior capsule versus the posterior capsule. You know you're in the posterior capsule because you got a really nice thalamus here on each side. This is part of the basal ganglia here. This is part of the basal ganglia here in a frontal section. Then this is the internal capsule. And then brainstem is down here. Your cerebral peduncles are right here, which is then it goes down through that crus cerebri, down through the pons, the front part of the pons, and then down here is your medulla and your pyramids. It comes down here and crosses over the other side. It's going to go lateral cortical, or it stays on the same side. One pathway down. 8 more to go. So, any questions on that? That was the medial cortical spinal tract, and then lots of anatomical reference points for now. These other ones should go quick, I promise. So the next one is this medial vestibulospinal tract. Function. It helps to regulate activity at upper back and neck muscles in response to vestibular input. So if I'm sitting here and I start to lean forward, my vestibular system is sensitive to gravity. Okay, there's a certain part of my vestibular system that's sensitive to gravity. And when it's going down, it's saying, hey, your head is changing position relative to gravity. Signals go to some vestibular nuclei in the brainstem and immediately go to your neck muscles to say, turn on neck extensors to counteract gravitational pull of you bending forward. And that's a very kind of reflexive, primitive response, and it's a brainstem level activity. It's mediated by the receptor is the vestibular nuclei. The sensory signal goes in, tells the vestibular nuclei, hey, you're leaning forward. Send a motor signal now from the vestibular nuclei down the medial vestibular spinal tract to tell the neck muscles to turn on. Okay? And that's also if I lean sideways, or anytime I change my head in position relative to gravity or angular velocity associated with it, that tells my neck muscles to turn on appropriately to counteract that. So it begins right here. This is the level of, this is the medulla, right? Here's the pyramids right here. There's a group of nuclei. There's a superior, inferior, medial, and lateral. There's a group of 4 vestibular nuclei. This one just happens to start in the medial vestibular nuclei. It enters into the medial longitudinal fasciculus, the MLF. And it descends in the MLF until you get down into the spinal cord. And even sometimes in the spinal cord, they'll still call it the MLF. Some texts will call it the MLF all the way into the spinal cord. But texts like the one in your Crossman book, well, once it's in the spinal cord, it'll call it the medial vestibulospinal tract once it's in the spinal cord. Okay? But it starts off in the brainstem in the medial longitudinal fasciculus. You'll notice that that medial longitudinal fasciculus, it sits right on the tip. This is your medial lemniscus. They like to make this stuff hard. So that medial longitudinal fasciculus sits right on the tip of the medial lemniscus. The medial lemniscus is sensory, but this is a motor tract, the medial longitudinal fasciculus. But just don't want you to get those confused. But they're really close to each other. Here's the medial longitudinal fasciculus sitting right on the tips of the medial lemniscus. And then once it gets into the cervical spine, and it only really innervates upper thoracic cord. It only is the cervical and upper thoracic cord that it's done. It ends. Remember I told you that one disappears once you get down into the mid, lower thoracic, and lumbar spines. So this is showing you on this particular picture that as if it's innervating ipsilaterally. It's innervating the neck muscles on the same side as where it started. However, it actually is more bilateral in nature. They just don't show. And actually those, so you'd have ones that come over this way and cross the anterior white commissure and innervate the other side as well. Let me just erase that and just show you in red here. So you'd actually have some that split off here and come over to this side and innervate bilaterally. So for this tract, I want you to think it's more of a bilateral tract. It's innervating neck muscles on both sides than a purely ipsilateral pathway. Yeah.
Do the ones that cross go to the anterior?
Yes. Yeah. But that's not important to know for this pathway. I won't ask that level of detail in some of these medial. I want you to see it, appreciate it, but when we start talking about this, we'll start talking about how to group these, how to kind of think about them in their major functions as groups and those kind of things. And then break it down, you know, this is, again, it's medial and it's vestibulospinal. It's going to start in the medial vestibulospinal nucleus, it's going to go down the spinal cord, and it's associated with the vestibular system, so it's mainly neck and head, so it's probably going to stop, you know, so just kind of use those cues to help you reason it out. You're going to see the MLF pop up a lot, whether it's now in these medial vestibular or medial activating system tracts or when we get to the cranial nerve nuclei. So the MLF, this is the medial vestibular nucleus, and this is sending signals down the MLF right here, is this area right here. This is the MLF right in here. You will also see the MLF, the medial longitudinal fasciculus, is an interesting structure. It connects the abducens nucleus, the oculomotor nucleus, and the trochleomotor nucleus. These are all the eye muscle nuclei in the brainstem that control our eye movements. It connects them with the vestibular system. You really have to sync up your vestibular system and your eyeballs so that when you turn your head and try to keep your eyes on an object without losing it, you have to have your head is turning a certain amplitude and movement, but your eyes have to turn the opposite direction the same amount. Or if you want to keep your eyes and head moving together, so your head and your eyes and your vestibular system are linked together intimately, bilaterally, and they're linked together through this medial longitudinal fasciculus. And they're linked to your neck muscles too. So that's how the information travels between those nuclei and also to your head and neck muscles, so that when you turn your head and eyes, everything syncs up and they don't get out of sync, and so that you can keep images stable on your retina when even when your head is moving, I can still read that. Or if I decide to, I can move my head and eyes together and cancel that out. So it's like it's a system that allows your communication between those and your head and neck muscles, so that everything is synced up. Okay, it's your Steadicam system. You know, it keeps you, that keeps your everything, images and your head movements all lined up. You can see down here, this is the vestibular nuclei, which are located right here between the pons and the medulla. You've got an inferior, a medial, a lateral, and a superior. Don't need to know that now. Just so you know where these things are starting from. Christina Cooper, you're going to have a whole lecture on the vestibular system that gets in the detail of this, and also those connections of the MLF. Just know what the limited detail I share with you now. Now the next track is the lateral vestibulospinal tract. It's lateral, more lateral, so it's starting in the lateral vestibular nucleus, and it's starting in the vestibular area, vestibular nucleus, and going to the spinal cord. So what does it do? It facilitates anti-gravity muscles of the ipsilateral extremities, but it also inhibits non-anti-gravity muscles. So it does both facilitation and inhibition. So it tends to facilitate ipsilateral, tends to innervate just the same side it starts on, muscles, of the extremities, more like extremity stuff. And it inhibits non-anti-gravity muscles. Okay. And some of that depends on the position of your body, whether you're against gravity or not. Okay, so just think about that a little bit. So here it is, beginning in the lateral vestibular nucleus. And the lateral vestibular nucleus is a little higher. If you look here, see, lateral vestibular nucleus is a little bit superior. Here's the medial is down here, so it's a little higher, even though it's lateral, but it's a little higher than this position. And it happens to be up slightly in the pons. So here's the pons. It's in the lower region of the pons there. So here's the lateral vestibular nucleus. And just know that it descends as the lateral vestibulospinal tract and stays that way all the way down. And it just runs kind of in the tegmental region of the brainstem. There's not a really distinct location for it. You can't really pick it out. I wouldn't show you a cross section and say, a real cross section and say, what tract is that? You can't see the tract. It's a small tract. It's just running down through the meat of the brainstem. And it descends in the lateral vestibulospinal tract, and it terminates ipsilaterally. So here it is showing correctly that it terminates ipsilaterally in the upper and lower extremity anti-gravity muscles. So the lateral vestibulospinal tract actually makes it all the way down to the lumbar spine. So it facilitates extension, anti-gravity of the, so think about this though. In the lower body, when you're standing in upright position, anti-gravity is extension of the legs. For the arms, anti-gravity is flexion. So this pathway, if it's working properly, will tend to facilitate upper extremity flexion and lower extremity extension if you're in an upright position. And your body knows you're upright based on vestibular input, tells you if your head is upright and you're against gravity, and also proprioceptive input coming in from your bottom of your feet. The next track of the medial activation system, the gross movement postural system, is the tectospinal tract. And you guys know the tectum is that little back part of the midbrain that is the superior and inferior colliculi. Remember that? It's the roof of the midbrain, the colliculi together. This tectospinal tract, the basic function, it helps to mediate reflexive movements of the head and neck in response to visual stimuli. So this is where, remember I told you like the superior colliculus have to do with reflexive vision and your movement of your head in response to that visual thing coming into your field of vision. So if you see something coming, you're automatically going to look at it to see if it's a visual, if it's a threat or not, or what is that object coming in. and your eyes are going to quickly deviate even without you consciously thinking about it. This is because of the tectospinal tract. So a visual signal comes into to your eyes, into your optic nerve, and you have a collateral even before it goes to register in your cerebral cortex, in your occipital area. There's a little collateral of that signal that goes to the tectum, and it registers in the tectum that something's coming. Look that way. And this is the system that does this. This sends a signal to your neck muscles and to tell you to turn your head towards that direction. Okay. And this is what? This is just visual stimuli that we're talking about here. I'm assuming there's probably also an auditory part to this. They don't talk about it, but I'm assuming the inferior colliculus is associated with auditory. So I'm assuming there's a tectospinal tract that makes your head turn towards an auditory. You just can't help it but turn your head towards an auditory stimulus. So we're only talking about the superior colliculus, but there's probably an equivalent for the auditory. It's a contralateral pathway. Starts on one side, it crosses. This particular region is called the dorsal tegmental decussation. You don't have to have that memorized, but if you read it, I don't want you to get it confused with other decussations. If you read the dorsal tegmental decussation, just know that that is a crossing point for one of these, medial activating pathways. But it's different than the lemniscal decussation. It's different than the pyramidal decussation. So it's the dorsal tegmental decussation. It descends. This is where it answers your question, Christy. It descends in the medial longitudinal fasciculus. Even though this picture should show it running right here at the tip. It should be running right there. If it's truly in the medial longitudinal fasciculus, it should be there. But then once it's in the spinal cord, then we call it the tectospinal tract. However, some people will call it the medial longitudinal fasciculus as well, all the way down. So then you get it confused with the mediovestibulospinal tract. So for your purposes, you can say it runs down with the medial longitudinal fasciculus in the brainstem, but then it is in the spinal cord. We're going to call it the tectospinal tract, so we don't get it confused. And it took me like 10 years and reading 15 textbooks to finally figure some of this stuff out. So if you don't get it right now, that's okay. And some of the stuff is not as clinically relevant. That as we get closer to this exam, and I give you some speed, things to focus in on, it's good to maybe hear it once because you guys are doctoral level students and you can impress your friends with all this knowledge. But then we'll try to narrow you down a little bit. Okay. It terminates in contralateral motor neurons of cervical muscles. So there it is, to cervical muscles. There's no lumbar because it just stops in the cervical spine. This is just purely to help you turn your head towards that visual stimulus. But if you just know tectospinal, it starts in the tectum. Okay, I'm not even probably that concerned. This is a contralateral pathway. It just goes to neck muscles, turns your head, responds to stimulus, starts in the brainstem, ends in the cervical spine. Next one. So this is out of a different textbook, just because it was hard to find a good representation of this pontine / medial reticulospinal tract. Remember reticulo is just that reticular system in the brainstem. Okay, is that area just kind of in the middle of the brainstem. So this whole region right here down through the brainstem is called the reticular formation. This happens to start in the reticular formation. There's lots of stuff in the reticular. That thing's going to keep coming up, especially when we get to the brainstem. So pontine reticular formation right here. So this is it. It's a little more medial. It's kind of medial here. What does it do? It activates ipsilateral lower motor neurons of postural muscles and limb extensors. So postural muscles and limb extensors, okay? It tends to facilitate limb extensors. It tends to function pretty normally even if there's no influence from the cortex. Some of the other pathways we've talked about, they're little collaterals from your cortex, from that cortical spinal tract, go to talk to these little medial activating pathways to keep them appropriately active or not too active to interfere with normal voluntary movement. This guy works pretty well without any level of activity from the cortex. Some of the other ones, when you lose some cortical influence from the top down, they tend to go amok and they tend to interfere with movement. So this one tends to work pretty well even when you don't have cortical influence. It begins in the pontine and reticular formation, descends in the pontine or medial reticulospinal tract. And again, this is one of those pathways that it's just kind of running down through the front part of the brainstem, and it's nondescript. It's hard to identify. And then once that you can identify it more once you get in the spinal cord, and it terminates in ipsilateral motor neurons of postural muscles and limb extensors. So ipsilateral pathway. So we're going to take a break here, but understand so that we just talked about medial activating system. One track starts in the cortex. It's mainly contralateral. The other tracks all start in the brainstem. They tend to actually have some ipsilateral and bilateral connections. There's not so much of a concern about them being contralateral. They tend to activate muscles on both sides of your spine, both sides of your neck, girdle muscles, and those kind of things. Okay. Right now, these tend to bias extension in general, except for that one vestibulospinal tract that tends to do a little bit of upper extremity flexion in anti-gravity position. But most of these are biasing extension, and they're more primitive, gross postural movement stuff that isn't so contralateral in nature. They tend to have a little more mixed bag. So when you have damage to these pathways, you don't notice them as much like in a stroke patient because of a lot of the overlap between these pathways and the bilateral connections. And so somebody doesn't have, so if somebody has a stroke involving a region of their cortex or brainstem, they might have one limb that's totally paralyzed, but their trunk muscles may have a little weakness on one side, but it's not like the whole trunk is paralyzed because of these medial activating pathways. There's a lot more overlap in bilateral connections and ipsilateral connections and so forth. So you lose all trunk control normally. But okay. Let's take like a 7-minute break because we're going to have to come back in and hit that last half hour hard. This is a rough day. Another one of those rough. I must have lied when I said that other lecture was the hardest. This one's also a little bit challenging. Come on. So we're finally, here we go. We're finally moving away from the medial activating pathways and now moving to the lateral activating pathways. These are more have to do with, so these descend in the lateral spinal cord and they tend to synapse with those motor neurons and motor neuron pools in the lateral portion of the ventral horn, more distal extensors, okay, distal flexors, sorry, distal flexors, all right. They are more for fine movement and fractionation of movement. So when you're trying to do fine, fractionated, detailed movement rather than gross postural movements. So all the little manipulative things we do with our hands, even some of the stuff we do with our feet that's more like, manipulative and fine, fractionated movements. It means like moving individual joints one at a time versus moving whole limbs or whole parts of your trunk, moving individual joints from each other. That's what the lateral activation. And I think about that's more distal lateral to me. So, okay. 3 pathways that do this. The main big one that everybody knows about, has learned about, is the lateral cortical spinal tract. The other 2 are also brainstem tracts. Amazing how many, that's darn brainstem. It's just insane how much stuff is packed into our brainstem. All these pathways and then all those cranial nerve nuclei and all these other, nuclei associated with descending pain control and ascending influence over the cortex. But the 2 here are the medullary or the lateral reticulospinal tract and the rubrospinal tract. So they tend to influence more of those flexors muscles is what they're doing. They tend to influence more of the flexor muscles to help facilitate flexor movement. The lateral cortical spinal tract is really where you send that discrete voluntary signal to move those individual joints and muscles. Okay? I'm going to go through them. So we're talking about these 3 guys right here. The more lateral activating. They tend to influence more of this distal part of the motor neuron pool and more of these posterior associated that are more flexor in nature. Okay, flexor and distal. So here's the lateral cortical spinal tract, and look, the rubrospinal tract actually kind of overlaps with it a little bit. Some of the fibers are running right with the lateral cortical spinal tract down in the spinal cord. And then we have the medullary or lateral reticulospinal tract. So lateral cortical spinal tract, you already pretty much know this because we talked about the medial cortical spinal tract. This lateral cortical spinal tract just crosses over and stays lateral. So what does it do? If fractionation of movement, the ability to activate individual muscles independently of other muscles, begins in area 4 and 6 of the cortex. Brodmann's areas 4 and 6. Descends. All this is the same as the medial, right? Because they're all starting out together. Corona radiata, internal capsule, crus cerebri, ventral pons, pyramids. But now at the pyramids, it crosses over in the decussation of the pyramids. And then once it crosses over and goes in the spinal cord, is now the lateral cortical spinal tract. So these all start off together. About 85% of these fibers cross over to become the lateral cortical spinal tract. The other 15% stay on as the ventral or medial cortical spinal tract. Then it terminates on motor neurons or interneurons in the ventral horn to supply distal muscles. About 55% of those lateral cortical spinal tract fibers are going to go to your upper extremities, 20% to the trunk, and 25% to the lower extremities. Makes sense. We do a lot more with our hands. It's fine, distal, fractionated movement. So a lot more of our fibers are devoted to going to the arm. And then we also have a lot more space on our cortex, or surface area on the cortex is devoted to hand function because of that. So that's the lateral cortical. It's contralateral. This is purely contralateral pathway. Do I say that on there? Make sure you know this one's contralateral. Next one is the medullary or lateral reticulospinal tract. Okay, so reticulospinal, medullary. This one starts in the medulla. The other one was the pontine reticulospinal tract. This is the one we talked about as part of the medial activating system. It's more medial and it starts in the pons. This one's a little more lateral. It's a little lateral from that, and it starts in the medullary or medulla area. But it all starts in this reticular formation. This is all that reticular formation area. Starts in the reticular formation. What does it do? It's the regulation. It helps to regulate some tone. It's more inhibitory than facilitatory. So what it does is it helps to inhibit your tone in a way that allows you to move in a more fractionated way and use your flexors better, because you have all these other medial activating pathways that tend to bias extension. So this is a lateral activating pathway that helps to bias a little bit of flexion and inhibit extensors so that you can use your limbs more selectively and move individual joints and muscles more easily. However, during walking, the effect is reversed. So during walking, it tends to facilitate more extensors and inhibit more flexors for the lower limbs. But that's just kind of a footnote there. In order for this pathway to work and do its job effectively of inhibiting some of the extensors and facilitating some of the flexors, it requires good normal input from the cortex. Most of your medial activating systems and even some of these most of your brainstem pathways, as your cortical spinal tract is coming down through the brainstem, little collaterals are going off from it and influencing all the brainstem tracts. Some brainstem tracts work pretty well without a lot of influence from the cortex. Some require that cortical influence for them to do their job appropriately. When we get onto our lecture on next Tuesday about clinical, you'll understand when we start talking about what happens when you have a stroke in the cortex and how that manifests itself because of release of some of these brainstem pathways that no longer have normal control over them, and those kind of things that cause these stereotypical synergies and tone and all that stuff. So it begins in the medullary reticular formation. It's actually, there's this area right here. There's a thing called the nucleus gigantocellularis. There's actually a region you can kind of define in there that this is called the nuke, but you don't need to know that. Just know it begins in the medullary reticular formation. But if you see that term, nucleus gigantocellularis, that's just the starting point of the medullary reticulospinal tract. Some books say it descends ipsilaterally, but a lot of them mention bilateral connections. I would just say, just know it's not a contralateral pathway. It can be somewhat ipsilateral, but it's probably more ipsilateral, but it's also got some bilateral connections, is what my general feeling about it is. So that it's coming down here, it's connecting ipsilaterally, but it's got some bilateral connections. I don't know what the percentage is, but it's again, it's more postural movements and it's more bilateral connections. It terminates on motor neurons of postural muscles and limb extensors. So it's facilitating more flexors of postural girdle muscles and limb extensors for the lower body, especially if you're in standing or walking. So that's the reverse thing. So in the upper body, it tends to help flexors more. I should say flexors, like shoulder pecs to flex the arms, and inhibits the extension of it. But in the legs, if you're in a weight-bearing position, it tends to facilitate extensors in the legs. But if you're not weight-bearing, if you're laying down on your back, it helps facilitate flexors of the legs and inhibit the extensors. So it's all dependent on all that input coming into the interneurons at the spinal cord level from proprioceptors and all that stuff that help influence this. Then the rubrospinal tract. Function. There's some question about what the function is, but let's starts here. There's an area called the red nucleus. Rubro, red. Red nucleus is where it starts. The red nucleus, it's easy to see in just a normal cross section. You don't even have to do any staining. You see a darkened region here. That is where cell bodies for this rubrospinal tract start, up in the midbrain. Okay. What does it do? It's closely associated with the lateral cortical spinal tract. They think it helps to facilitate mostly flexors of the upper extremities. The reason they think this is because in monkeys and primates that do lots of climbing, which involves lots of flexing the arms, it's more highly developed, that rubrospinal tract. So it's probably maybe left over from an evolutionary standpoint if we were doing more climbing in the past, which we don't do as much of, but it helps facilitate flexion, they think, of the upper extremity, because when they lesion that they notice that the primates don't have as good as ability to flex their limbs, upper limbs. Okay, so it just enhances. It's an enhancer of flexion, they think, of the upper body. It begins in the red nucleus in the midbrain. It crosses immediately in the ventral tegmental decussation. So remember that tectospinal tract back here? It crossed in the dorsal tegmental decussation before it went down. So this little region right here, that they divided into a ventral and a dorsal tegmental decussation. So that's not that critical to know, but that's the ventral tegmental decussation. This whole middle region of the brainstem, even that's the reticular formation is inside of this. That's called the tegmentum. That big middle region is the tegmentum, and then you have a reticular formation on each side of that tegmentum. So it's called the tegmental decussation. It descends in the tegmentum of the pons. It's kind of, again, a nondescript pathway in the pons. It joins the lateral cortical spinal tract in the spinal cord. So then eventually it becomes and joins up the lateral cortical spinal tract, like you saw in that previous picture where it actually almost overlaps with it. Okay, so then becomes that. And it terminates on motor neurons or interneurons in the ventral horn, primarily supplying upper extremity flexors. This is another pathway that needs cortical input, collateral influence from the cortex to help it do its job effectively in facilitating upper extremity flexion. So when you lose cortical input like a stroke, the rubrospinal tract can't facilitate flexors, or it over-facilitates, I'm sorry. Normally the cortical influence keeps this regulated down a little bit so it's not creating too much flexion. It helps to facilitate flexion, but you want to balance between flexion and extension. So when you normally have cortical influence over that, it keeps it at a level where it's the appropriate amount of upper extremity flexion activation. When you lose that input, it gets overactive. It actually, so the cortex inhibits it a little bit. When you lose the cortical influence, it starts to go overactive, and that's why when somebody has a stroke, their upper body tends to do this. They have this we call flexion synergy and flexor tone because the rubrospinal tract's been released from its little control from the higher centers, and it's overactive. So we'll get into that on Tuesday. Lastly, yeah.
On that last track, does it go to the lower extremity?
No. Well, minimally if it does. It shows it here, but I don't believe that most books would show it or talk about it. I've never heard it talk about going to the lower body, like it ends somewhere in the thoracic spine. But good pickup. I'm going to mention these briefly. We're going to talk about them when we get to we're going to do all the cranial nerves at some point, so this will come back up. We have a cortical bulbar track or system, okay? So remember I said this is all the information or motor system for the neck, face, and tongue. The rest of this region of our cortex is all of our body. And that's what we talked about when we talked about the lateral cortical spinal tract is going to the body. All the rest of these fibers that are coming from the face, neck, and tongue, they go through the corona radiata, they go down the crus cerebri, but then they cross over at the appropriate level in the brainstem to send their motor signals to cranial nerve nuclei associated with, and this is the cranial nerve 11. They dump that off, but collectively all of these are called the cortical bulbar tracts, the cortical bulbar tract that comes down, and then they just deliver their motor information to the appropriate cranial nerve nuclei to send the signal to the muscle of the face or neck. On the opposite side, these are all contralateral, except for the upper face. Upper face tends to get bilateral innervation. Don't need to know that now, but when we get to the cranial nerves and we get to clinical things, you'll be a reason why when somebody has a stroke, the upper face oftentimes doesn't seem to be paralyzed. The lower face is more paralyzed than the upper face because you get bilateral connections from both sides of the brain, so it can make up for it. So then we have what we call non-specific activating pathways. A couple more. These are collectively known as the cerebriospinal and raphe-spinal tracts, which you've seen before. Remember we talked about the cerebriospinal and raphe-spinal tracts. They play a role in descending pain control, right? They fire inhibitory interneurons at the dorsal horn to inhibit pain, but they also influence motor neurons too. They have general effects on motor performance and motivation. They will tend to upregulate or downregulate the anterior horn in a more general nature. This is where they think like somebody who has the yips, or the yips are when you're like standing over a putt and you're like, oh, and you just blow it, and you can't because you're freaked out and you're thinking about it too much, or you're stressed or anxiety, or that poor kid last night who fell doing the whatever, who's the Chan or somebody, who's the next golden child for, is it Chan? Yeah, but he's the guy to do all the quads, but everybody, all the it was like the men's short something team thing, but they were all of them are falling, you know, and of course in practice you can just do it fine, but when the stress, the cerebellar and raphe spinal tracts, these primitive brainstem tracts in your reticular formation area, they get all ramped up and they start over-activating your anterior horn. So when you do send the signals, you screw up because you get, it tends to facilitate more bilateral contractions, so you get stiff, you know, and you can't, and you also you can't turn muscles selectively on and off as easily. You tend to just fire lots of more anterior horn cells than you need for the task, so that it makes you kind of stiffen up. So the cerebellar and raphe spinal tracts are speculated to influence, you know, so that's the difference between, you know, people like a Tiger Woods or something like that who can turn down those raphe spinal and cerebellar spinal tracts during the worst, most pressure situations and not let it, and that's the difference between them and me, who just turns into a puddle mess if even you know, somebody looks at me wrong when I'm up on the tee, or I hear a bird chirp and I'm like, I just get distracted. It's because I cannot turn off those tracks or moderate those. So. So we talked about there are areas of the motor cortex that influence the motor pathways, particularly the lateral and medial cortical spinal tract, obviously, because they're coming from the cortex. We have the primary motor area, which is that precentral gyrus, which is also known as Brodmann's area number 4. It's for primarily that movement, execution, and fractionation, sending those discrete signals to select muscles to move individual joints and muscles. More than 50% of your primary motor area is devoted to hand and speech. Then we have the supplementary motor area, which is area number 6, and it's primarily active prior to bimanual tasks and tasks that require sequence of movements. So especially so things like, you know, like opening a jar is a bimanual task. It requires a sequence of movements. So you got to grab the jar, then you've got to twist the lid while counteracting the force, and you're using both limbs. That's a little mini program stored in the supplementary motor area that helps. You know, you have to learn that, but then once you learn it, part of that is stored in that supplementary motor area, and it sends signals to allow that kind of stereotypical task to occur. The premotor area generates patterns of movements involving multiple muscle groups and joints. So more like, you know, sit to stand, you know, like that task of sit to stand. That requires multiple muscle groups and patterns of movements, or a lot of repetitive movements that are sports related, you know, doing a high jump, you know, and doing that kind of stuff. The premotor area is particularly active prior to and initiating and helping us to do those types of tasks, okay? We already showed you those regions, but we'll show them again. Primary motor, area number 4. The whole region just in front of the primary motor is the area number 6 that's subdivided into 2 named areas called the supplementary motor area. And I think supplementary because it's superior up here. It's in front, but it's superior. And then premotor, it's in front, it's pre, but it's below here, the supplementary motor area. That's the premotor area. Yeah. Yes, there is, but I don't remember what it is. Actually, it's part, no, it's not, 1, 2, and 3, 5, I think is somewhere in one of the regions of the parietal lobe. But not necessarily, you think it would. Because actually 1, 2, and this is actually 1, 2, and 3 are right in here. But the 3 is over here versus, yeah, it doesn't go quite right in order, which is, because this area down here, this is area 44 and 45, right down there, so. Yeah.
In the lateral cortical spinal tract,
Yeah.
you want to go to the picture? There's like red axons that come out from the bottom.
Come on. Now my computer's locked up. Oh. PowerPoint has stopped working. Can I cancel? Oh my gosh. Well, that sucks. Thanks for Jenna for screwing me up here. Hang on. Let me